Good evening, everyone. Thank you so much for joining us for our presentation and discussion, Shortness of Breath as a Post-COVID Symptom, What Have We Learned So Far, with Dr. Donna Goodridge and Dr. Mark Fenton. My name is Jill Hubeck. I'm a registered nurse and certified respiratory educator with Lung Saskatchewan, and I'm just so pleased to be your host tonight and to be your moderator this evening. Before we begin our discussion and presentation, I really want to acknowledge that the land that we are hosting this webinar on is Treaty 6 territory, which is the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as the territory of the Métis. Lung Saskatchewan affirms our commitment to reconciliation, and the Truth and Reconciliation Commission of Canada calls to action. We are very committed to acknowledging the many First Nations, Métis, and Inuits whose footsteps have marked these lands for generations. And we're just so grateful to be here tonight and to be able to host this webinar where we are. Following the presentation, we will have time for a moderated question and answer period. So if you have questions for our amazing researchers tonight, don't be shy. Please ask your questions. You can type them right in the software. You'll see it on the right-hand side of your panel there. And like I said, don't be shy. If you have questions, chances are someone else has the same question as you, so go ahead and ask it. This presentation will be recorded, and we will be sending a link out to everyone that's registered tonight of the recording, as well as it will be posted on Lung Saskatchewan's website, lungsas.ca. So if you missed anything, you can watch it again, or you can share it with friends and family, which we hope you do. All right, well, COVID-19 has impacted all of us, and sadly it continues to do so, and it creates ongoing burdens. And on behalf of Lung Saskatchewan, I just want to take the time to acknowledge the many healthcare providers and champions in lung health, like Dr. Fenton and Dr. Goodridge, who have gone above and beyond and continue to do so. And they're so invested in our future and helping people breathe easier. So thank you so much for all you've done, and to all the healthcare providers out there that continue to help us breathe a little bit easier and go above and beyond. We thank you for all you do each and every day. And being a nurse with Lung Saskatchewan, I think it's imperative that I also recognize that this pandemic has been incredibly hard on people with lung disease and incredibly challenging for their caregivers as well. And Lung Saskatchewan hopes to continue to support people living with lung disease as well as their caregivers. We do offer a variety of online support groups that we'd love to have you be part of. Our support group spaces include asthma, COPD, pulmonary fibrosis, COVID-19, lung cancer, lung transplant, sleep apnea, and Saskatchewan Quits to help you quit smoking. And really, these spaces are a safe way for you to help manage your lung disease and navigate through a journey, knowing that you're not alone. It's also a great way for us to share information and education opportunities like tonight. So if you're not part of our support groups and you want to be, we'd love to have you. Just check us out on our website at lungsas.ca. Okay, and many members of our COVID-19 support group in particular have expressed that after having been infected with COVID-19, they experience shortness of breath or dyspnea. So we're really looking forward to tonight's presentation, learning more about this, as well as how we can get involved to make for a brighter tomorrow. Okay, so it is my absolute honor to introduce our presenters and research this evening. They are two of my lung heroes. I'm going to start with Dr. Fenton, who was born and raised right here in Saskatoon. He did an undergraduate master's and medical degree at the University of Saskatchewan. Go Huskies. He first trained in internal medicine and later in respirology. Dr. Fenton also completed fellowships in lung transplantation and sleep medicine. This is impressive. He's currently the director of the Lung Transplant Program, medical director of the Sleep Disorders Center, and program director of the Respirology Training Program at the University of Saskatchewan and Royal University Hospital right here in Saskatoon. And certainly if anyone has had a lung transplant or is going through a lung transplant journey, chances are they will know Dr. Fenton. He is often being referred to by his patients as Superman, and he's so well loved by his patients. He's personable, caring, and so dedicated to helping others. So thank you for being here, Dr. Fenton. And we have also the amazing Dr. Donna Goodridge, who is a professor in the Division of Respirology, Critical Care, and Sleep Medicine at the University of Saskatchewan. She is so involved in our community. She was the co-chair of the Canadian Thoracic Society COPD Clinical Assembly from 2011 until April of 2018 and is a member of the CTS Choosing Wisely Task Force. Dr. Goodridge is a co-director of the Foundation's undergraduate respirology module in the College of Medicine at the University of Saskatchewan. Oh my goodness, and she has received extensive training in realist evaluative approaches and mixed methods and uses these methodologies in her current projects related to improving health services deliveries, which all of us patients are so grateful for. She has a research interest in how mindfulness-based approach may improve the wellness of people with respiratory illness. And how fitting is that? Dr. Goodridge is a member of the steering committee of Age Friendly and works closely with members of the Saskatoon Council of Aging and other community-based groups. She's also, on top of all of this, the director of the Respiratory Research Center at the University of Saskatchewan. Wow, how lucky are we to have you both? Thank you for being here. Without further ado, I will pass it along to both of you.
Well, thank you so much for those introductions, Jill, and thank you so much to Lung Sask for everything that you do to support our patients in the community. I know that there is the needs are great, and Lung Sask just does a phenomenal job of addressing those needs. So our presentation today is going to be basically a sort of fireside chat. I'm going to ask Dr. Fenton some of the questions that I've heard from my contacts with people that are dealing with persistent symptoms of long COVID. And he's going to bring in some of the newest evidence to help to address those questions. And he's also going to, I think what I like about this presentation is give us a really specific Saskatchewan focus on, what's happening here. So the first question that I want to start off with is, Dr. Fenton, can you explain what is dyspnea? What does that mean?
Right. So it's a term that gets used a lot, but maybe isn't well understood. It's a subjective description of the sensation of feeling short of breath or having difficulty breathing. That's its simple definition. And so for the most part, we equate it with shortness of breath, and this feeling of I can't get enough air would be another way a patient might describe it. So it's very much driven by the subjective sensation of the individual.
Okay, so it's what the person's feeling. So what are the connections between sort of dyspnea and heart rate? How do the heart and lungs kind of work together to?
Well, to answer that, you kind of have to dive in, well, what causes this? And it's a symptom complex that can be driven by a lot of things. Okay, so the two most common organ systems one might think of are the respiratory system and the cardiovascular system, but other things can produce this as well. So within the context of that, I'm going to back up for a second, just say kind of try and explain it from the perspective of movement. So if I get up to move, if I got up to walk across the room, there's an integration of a whole lot of things happening in my body. My brain is telling my muscles and nerves, okay, I want to move, I want to go over there. And then the muscles start to carry out that action, and they start asking for things. They start asking for oxygen and energy, and the blood needs to deliver that, and the heart needs to push the blood to deliver that, and the lungs need to pick up oxygen from the air and expel carbon dioxide to do that effectively. So when you start to disrupt any of those systems, that can actually create the scenario where a person might feel short of breath for any number of reasons. So when you think of the lungs, it could be that it could be centrally driven in their brain because that's where we control breathing. It could be related to mechanical issues in our chest, or it could be related to things directly within the lungs themselves. They may be damaged or inflamed and so on. Similarly, in the cardiovascular system, if the heart isn't pumping as well as it could or should, a person may feel short of breath related to that. And that could be related to issues with heart rate, which is your original question, which could be, the heart rate might be high, for example, related to the fact that it's not pumping very well, and that would be a compensatory mechanism. Or maybe they have an arrhythmia that has a high heart rate. So I guess to answer it simply, it's a relationship that is really complex. I think I've illustrated that. And so teasing out the cause in an individual requires some thought and attention.
So just to kind of build on your comments, is there a relationship between dyspnea and the mind, like anxiety, some of those,
Yeah,
you talked about central mechanisms, but I think that's a little bit different than maybe anxiety. So could you tell us more about that?
Yeah, like the central mechanisms are things we don't control. They're done automatically in the lower part of our brain. And what you're talking about is anxiety, which is, above the tentorium, as we say in medicine. So in the cerebrum where we do our thinking. And, the anxiety can be a driver of a sensation of shortness of breath. Anybody that's had a panic attack would probably tell you that that's very much a part of that. Or even lesser forms of anxiety can produce that. And of course, the flip side is being short of breath can make a person anxious, right? And sometimes, particularly in a patient that has some lung disease, teasing out what's driving what is sometimes a bit of a challenge, both for the patient, but also sometimes for the clinician. So it definitely can contribute. But as I said, it's one of many things. Anemia would be another cause, other metabolic issues too. So, I think to me, it falls into the category of one of the many causes as opposed to a default cause. Yeah.
So it's not always just the lungs that are involved?
No, not by a long shot. Yeah.
Okay, so that's interesting, because I think that sometimes we assume that when we can't breathe, it's because we have a problem with our lungs. But what you're saying is that it could be something with our heart, it could be something with our sympathetic nervous system, it could be many kinds of things that are contributing. So
Yes.
I think that leads into our next question, which is like, why do people have problems with dyspnea after a COVID-19 infection? Like, why does it, I mean, lots of us have had the flu. We can't breathe for maybe a few days. It's hard. And then we get better and we're okay. But with COVID-19, it seems like things like dyspnea might last longer. And maybe could you tell us a little bit about how that could happen?
Right. So, in the acute phase of illness, feeling short of breath, whether it's from COVID-19, influenza, which you referenced, or other viral illnesses, is not particularly uncommon. And each of those viruses behaves differently. They're not the same. And some take longer than others to resolve. In the context of COVID, what we've learned is that symptoms can last up to 4 weeks after the initial infection starts. So it can take quite a while for things to settle down in the acute phase, and even longer in some patients. And once it's stretched out to, say, 3 months, that's sort of the accepted cutoff where you start to think this is now chronic long COVID type symptomatology. And that's driven by things like inflammation, particularly in the initial phases, and then recovery from that. But there can be other reasons why a person might feel short of breath. Some people could be that they've had some anxiety associated with having COVID, to your example of that. Or there may be some, depending on the severity of the illness that they present with, there may be some actual damage done to the lung that's persistent. So it's quite contextual to the individual.
And so do you think deconditioning plays a role? Could you maybe talk a little bit about that? Like people that have been really sick, not able to sort of move, like what happens in those cases?
Yeah, so back to my example of movement, with muscles, use it or lose it is a real phenomenon. And so if you've been lying in bed for say 3 weeks, and you're perfectly fit and healthy before that, it's going to be a bit of a struggle when you get up to move after that, because the muscles haven't been put to the test and have started to decondition. And so that can produce some shortness of breath and fatigue.
So one of the questions that I would like to ask you is, like, should people try to exercise after COVID infection if they're short of breath? How do we manage all of, often if someone's short of breath, the advice is like, you should get out, you should walk, you should do things, you should and where does physiotherapy come into this? Like how do people actually, how should we sort of work on this situation?
Right. Boy, there's a lot to unpack there. Okay,
Yeah.
so, I'm going to answer the physiotherapy part second, but, repeat the first question again.
Well, it's really, should people try to exercise after
Sorry.
they've had a COVID infection? Because I've heard from many patients now, actually, that the advice they're getting is that, they need to start to exercise. But for some patients, it's really hard. It's actually impossible to begin to exercise because for multiple reasons, for fatigue, for shortness of breath, for all kinds of reasons. And so I'm just wondering, how do we navigate this?
Right. Okay. So, I think the context of the individual really does have to be considered in the answer to this question. So, and by that I mean, if depending on how bad the symptoms are, that should dictate how much you should be expecting of yourself, for starters, in terms of the activity that you do and how we define exercise. I mean, as soon as I say you should go exercise, Donna, you're already thinking, what kind of running shoes? Am I wearing Lululemon or Nike or, we have this mental construct around what exercise is. And really the point of this is, from my perspective as a physician, is actually it's around function, meaning can you walk? Can you achieve the things you need to do just to maintain your life? And so, by saying I want you to move and exercise, it's really I want you to do what you can within your symptoms, and that will be dependent on where that person is at, right? And the long-term goal is that you start to build some capacity, assuming there's some impairment to start with. And so, how does a patient navigate that on their own? Because they can, and it would be pay attention to yourself. I always tell patients, I don't want you passing out. I don't want you turning blue. If you have chest pain, that's a bad sign. But if you're feeling a bit short of breath and breaking a bit of a sweat because you're trying to, even if it's only for a short distance, that to me is a good thing for you, because it's prompting all those systems I talked about earlier to step up their game and start to get back in the game. The British, there's a publication in the BMJ sometime in the last year or so, I can't remember the exact date, which actually provides some guidance for people. It uses something called the Borg scale, which is a gradation of dyspnea, and then some guidance there around, well, if you're in this zone, you need to really take it easy. But if you're in this zone, you can go just a little bit harder, and it has strategies, stay in this zone, in the low zone, for example, for a few weeks before moving to the middle zone. So that could be quite useful to patients. With respect to the involvement of a physiotherapist, physiotherapists are our partners for a reason. They have a lot to offer patients that doctors can't offer. And so, does every patient that has shortness of breath from COVID need to see a physiotherapist? I think the answer would be no, but there would be situations where they could be helpful. So for example, if one of the drivers is muscle weakness and fatigue and so on, they could be quite helpful there. Similarly, people that have, there are some patients that have sort of uncoordinated breathing patterns afterwards, which is not super common, but it's out there. They can help them with, training to try and sort of overcome that and reestablish a more normal pattern. So in response to activity.
Okay, well, thank you. That's really helpful. So after someone's had something like COVID, like what is usually how long does it usually take for someone to recover from their shortness of breath? Like when should they start to say this is too long? I've been living with my shortness of breath for too long, and I need to see I need help. I need more help than
Right. So the I need help question again is contextual. So, if even early in the phase of illness, if somebody's shortness of breath is just getting worse and worse and worse and worse, that's a sign to go seek attention, right? But let's just talk about it as if it's someone that doesn't need to be in the hospital, has some shortness of breath that's persistent over the course of that first 10 days or so where you're infectious and then into the subsequent weeks. Most people will recover within about 4 weeks. That's the usual timeline. And of course, not everybody follows the textbook, but that's most people that recover within that time frame.
Okay. So is it at that point when do you suggest people see a doctor about their dyspnea? Like when should they seek attention?
Yeah, so if it's persisting beyond that 4 weeks, 5 weeks, if you're getting into that time frame, that's the time to start thinking, well, maybe I should go see my doctor about this to see if there's something going on that needs attention. And what that something might be is, as I said, quite a broad differential of what's potentially causing shortness of breath. Having had COVID helps narrow the field a little bit, but yeah, that would be my thinking, is that once it's going past 4 to 5 weeks, that would be a time to go see your family physician to say, hey, I'm still having symptoms.
So when I go to my doctor, what kinds of tests might he or she order to check my dyspnea out?
Right. So they'll presumably do a physical examination to listen for abnormalities that might lead them to one sort of particular area of thinking or another. They'll probably be able to check oxygen saturation as well. And then in terms of tests, they might do a chest x-ray depending on what they hear. They might do spirometry. Some offices have the handheld spirometers in them, which is a measurement of lung volumes that can be quite helpful. Some may send a patient for a full pulmonary function test, perhaps, and then blood tests. It'd be good to rule out anemia as a cause of shortness of breath in some people, depending. Things like that.
So if I've gone to see my doctor and they're not quite sure what to do, what are the criteria for referral to a respirologist? Like when should I expect that I would be referred to see someone like you?
Right. As a general rule of thumb, a family physician or any other physician that's encountering a respiratory issue in a patient would ask for, say, my involvement when they've reached the limit of what they feel they can do, either from a knowledge base or from a treatment perspective. Once they've reached their own limits, that's generally when they try and get a specialist like myself involved. And there's no sort of written, you have to be, have an oxygen saturation of this or a lung function of that. There aren't those kinds of specific criteria. So it's going to be very dependent on the comfort level of the doctor that is sending the patient to me. Because
not everybody needs to see a respirologist.
No. In fact, the current sort of build or development of the long COVID pathway in Saskatchewan, it doesn't quite yet exist, but is coming, is not predicated on everybody seeing a respirologist. It's not really a manageable thing for there aren't that many of us. But at the same time, it's designed to put the tools into the community so patients don't have to travel to Saskatoon or Regina, that's where respirologists are in Saskatchewan. And a lot of our patients and live outside of the two major centers. So it'd be nice to have strategies out in the community to deal with the majority of this, and then involve respirologists where we can be most effective and helpful.
Okay, so thank you. So when I go to see my family doctor, what kind of medications might they, like what could I expect? Are there medications they could give me? Like what are they and how long should I use them for?
Right.
Is there anything?
Well, let me start by saying there is no pill for long COVID.
Okay.
There's no specific sort of medication that I could say, aha, give that for long COVID. But there may be instances where a patient would benefit from using a bronchodilator, something to open up the airways if they've got evidence of airflow obstruction. So sort of asthma-like scenario might be helpful in that context. So there aren't any specific pills or treatments that one should walk in the door saying, I better be getting this at the end of this visit, because it's going to be driven by what the doctor thinks is wrong and whether or not a particular treatment might be effective. And then, things like the office spirometry may help them with some of that decision making.
So can you tell us a little more about spirometry? What is spirometry? Like, what does it actually tell us? How often should we repeat a spirometry if we're not feeling, like, have the spirometry repeated if we're not feeling better?
Right. So, spirometry, let's start with what it is. So it's a clinical tool. It's a test that is very much a patient participation test. Okay. So, the patient really actually has to work quite hard in it, where they take a big deep breath in to as big as their lungs can get, and then blow out as hard as they can for as long as they can, or until the person that's doing the test with them tells them to stop. And it gives us sort of two principal measurements. One is the forced vital capacity, and a vital capacity is basically the amount of air in the chest that's usable to a patient. Okay, it doesn't account for all the air in the chest because we can't blow all the air out. This is just a measurement of what we can get out. Okay, and then the second one is forced expiratory volume 1 second. So that's basically what's the volume of that total that came out in the first second. How easy does it come out? And in normal circumstances, it comes out very easily. And so if somebody has asthma or COPD, what we call obstructive lung diseases, then it's harder for it to come out. So it takes longer. And so that's a tool that's very good at identifying that particular group of diseases, as well as what we call restrictive diseases. It may give us clues to that, but we have to do more advanced testing beyond that to confirm it. So complicated answer. So in the context of a patient who's feeling short of breath from COVID, they may choose to do this test. And if it's normal, repeating it probably isn't going to be of any particular use down the road unless something changes, right? If things are getting worse, maybe repeating it might be worthwhile. If it's abnormal, depending on what the abnormality is, they may want to repeat it at some point to see, is it still like this, or has it responded to whatever treatment I have employed? Does that make sense?
Mm-hmm.
Yeah.
So some of the people I've talked to have had spirometry done, and they were told that their results are normal, but they're still really short of breath. So can you tell us a little bit about maybe what could be happening there?
Okay, so as we kind of alluded to before, it's not just the lungs. It could be something else. And so to me, if the spirometry is normal and they don't have any symptoms that make me think that there's, background asthma that I need to be doing some additional testing to look for, then, I might do a full pulmonary function test if all they've had is spirometry, because for me,
Can you tell us the difference between those two?
yeah, so I'm about to, yeah. So for me, what that gives me is a better measurement of what we call static volume. So I can actually see all the volumes in the chest with that technique. But also importantly, in this context, something called diffusing capacity, which tells me about gas transfer from air to blood through the lining of the lung. And so that one would be a useful test to me, to be starting to think about some rare causes of shortness of breath in someone that has had COVID. Yeah. So back to the question about, they're telling me my test is normal and I'm still short of breath. I still have dyspnea. Unfortunately, I see that. And I say unfortunately because it's very dissatisfying for the patient when I say, I'm sorry, I can't find a cause that I can put my finger on and say, aha, this is what's wrong with your lungs per se. And so we have to think about, well, what else could be contributing to shortness of breath in this individual? And, you know, it's not a question of saying the test is normal doesn't mean we don't believe you. We do believe you. We want to help you. But we have to start thinking, well, what else could it be? What other tests do we need to think about? Is there something with the heart? Is there something with the blood? Is there something with the muscles? You know, that going back to looking to those first principles of, well, what could be causing this?
Okay, thank you. So for people maybe that have had diagnoses of asthma or COPD in the past, what, you know, how might COVID affect them? Would it have necessarily made their asthma or COPD worse or better?
Not better generally, but you know, in terms of worse, I mean, this would be a well described trigger for an exacerbation of either of those diseases, just like many other viral illnesses. So the common cold, which is a coronavirus, could also trigger that in a COPD patient, amongst many others. So you may see in that acute phase of illness that they have, in addition to having COVID, now they've got an exacerbation of this underlying disease, which complicates things for them. In the context of either of those, depending on the individual and how their body has responded to the virus and what treatments have been employed and so on, it may take a while to recover. You know, it's not unusual in a COPD patient, for example, for them to take weeks, sometimes even months, irrespective of COVID, to get back to feeling like they're at or near their baseline before they became sick. Some people never get back to that baseline even.
Okay. Some people have asked about pulse oximetry and using pulse oximetry at home after they've had a COVID infection, and wondering about what kinds of changes they might see in their pulse oximetry after they've had a COVID infection. So could you maybe talk about that?
If you haven't needed your oxygen monitored while you're acutely ill, I'm not sure you need it monitored after you've recovered. So, you know, I wouldn't be recommending to people in general to go out and buy pulse oximeters just because they've had COVID. You know, I think if somebody's had a severe illness, like they've been hospitalized and or in the intensive care unit or something like that, maybe there will be a role for that in that individual, depending on how things evolve. But that would be, you know, I would still suggest that people talk to the physician that's taking care of them to say, is this going to be a useful tool? Because they're not inexpensive, and they can also be distracting for people too, in the sense that, like any tool, you have to know what it's for and when it might not be accurate, and where it's not a person issue, but an issue with the test, right? Because there are ways that it could be falsely low, for example. And so, you know, I think you just need to think those things through a little bit to see, like, is this going to be a truly useful tool or just a distraction and maybe even a source of concern and worry over the long term?
So it could be helpful for some people in some circumstances. Yeah,
Yeah,
because
so
pulse
I
oximeters,
think in a
like, they're available everywhere, right?
Yeah, but in a targeted manner. I mean, honestly, like, if everybody listening to this decided they wanted to go buy a pulse oximeter, I'm not like going to be like, oh no, you did that. But rather, is it worth the money for you? Is it a good investment of your money and time if it's not really necessary? Is kind of the perspective I'm coming at that question with.
Okay, perfect. And so, staying on the oxy topic,
Yeah.
what are the criteria for prescribing oxygen and getting oxygen funded? Because some people, like, their shortness of breath is just, you know, they have been prescribed oxygen. And so
Right.
can you tell us a little bit about that?
Well, let's just back up for a second, just separate shortness of breath and oxygen from each other just a little bit, because
Okay.
you don't necessarily feel short of breath with low oxygen, nor does shortness of breath mean that your oxygen is low, right? So so just reflexively giving oxygen because somebody's short of breath is not necessarily the treatment strategy that should be employed. There's criteria, as you alluded to, for coverage that the Saskatchewan Aids to Independent Living, so that's a branch of the Ministry of Health, will provide oxygen to anybody that meets the criteria. And that's either through a blood gas where you sample blood out of an artery and look at the partial pressure of oxygen, and if it's below a threshold, they'll pay for it. Or if there's a recording of oxygen saturation resting that sits at below a certain threshold for a period of time, that would be an alternate criteria. So there's specified criteria. It's easy for us to arrange for patients, us being doctors, to arrange for patients to do. But I think it's important to dispel the idea that because I feel short of breath, I have to have oxygen, because that's not necessarily the case. I mean, by that, I mean supplemental oxygen. We all need oxygen, but yeah.
So you're not a fan of oxygen bars?
No, a
No.
waste of money. Yeah.
Okay. Well, I think they've kind of run their course anyways.
Yeah.
Thank you. So I'm just wondering about, you know, if somebody is feeling short of breath, like
Mhm.
what might they do to help themselves? Like, is there anything they can do as a self-management kind of strategy to help make their shortness of breath better?
Yeah.
Um,
Yeah. So, I guess it's hard to answer that without the context of a patient, right? In the sense that, if it's truly a lung-driven issue, you might employ some strategies to help them start to control their breathing a little bit, like pursed lip breathing, for example, where they take a breath in through their nose and then like that. If it's anxiety, sometimes square wave breathing can be helpful, where you like count in for 4, out for 4, which is not a normal respiratory cycle in terms of the relationship between in and out, but it does help settle that. Or some patients find a fan sometimes helpful if they're feeling short of breath, and it's probably something to do with cooling the air that's going into their nose and the mucosa of their mouth, and that sending a signal to relax. But in many patients, particularly people that have been a little bit sedentary for a while because they've been sick and sometimes afraid to move, right? Like there is that fear of testing my shortness of breath. I usually say, like, try and just see where you're at and see if you can build on it. And if you can start to build some capacity, that's a very good sign. But if you're trying and it's not getting better, that's not such a good sign. And that requires more thought and attention from people like me. Does that make sense?
yeah, yeah. So is there anything that people that have shortness of breath should avoid?
Sitting still continuously.
Mhm.
Honestly, right? Being sedentary isn't helpful, irrespective of your cause of dyspnea. Being still, which is like, it's an understandable response. Don't get me wrong, I get it, right? It sucks to feel short of breath. It's not a comfortable feeling. And regardless of the cause, and I see lots of people with very advanced lung disease because of my work in transplant. And I have this conversation with them as well. You need to move in order to maintain what functional capacity, what you can do has to be maintained, because if you sit still, it will go away, and then getting it back will be very difficult. So that's where that comment came from. In terms of like avoiding certain environments or certain activities, I think, the answer is not, there are no specific things that I would recommend in that regard, but back to my statement about pacing, that's the important thing, is like, do it within your symptoms, do it within what you can do reasonably. Don't set yourself up for feeling like a failure because you want to run a marathon when really you need to just start walking instead, right? And we all do that to ourselves. I'm certainly guilty of that, where I set the bar just a little bit too high, and then I'm saying, well, geez, I didn't get there, and then it can be frustrating. So pace yourself, set reasonable goals, but there's no specific thing that they have to avoid per se.
I'm just wondering, you know, right now it's going to be, I think, tonight's only -20, tomorrow's -33, and the humidity in my house is like 20%.
Yeah.
Is that something that could make things worse?
It could certainly drive symptoms. There are people that find cold air can be really challenging for them. Asthmatics would be the classic example of that, because it can actually trigger bronchospasm. But even people that don't have lung disease and people that do have other lung diseases will sometimes report cold air makes me feel more short of breath. So if that's the case, then I would avoid it because it's giving you grief. Unless you have to be out to take care of the things you need to take care of in life.
Okay. And I have one last question. And can you just talk a little bit more about how shortness of breath affects exercise capacity, our ability to move, and how could we actually measure what our exercise capacity is, or how could it be measured?
Right. So let's talk at the patient's perspective to start. Well, you can do that for yourself. What can I do today? What is it that I can do? That how far can I walk before I have to stop? That's your personal measurement of what your capacity is at the moment. And then that can be your benchmark to work with if you're trying to build on that. In terms of what people like me can do, I can do lots of things. So there's 6-minute walk test is a standard test where we get patients to walk in a very specified way over a specified distance back and forth over a period of 6 minutes. And we know what to expect based on their age and their sex and so on. We can do even more advanced testing, cardiopulmonary exercise testing, where we have them on a bike and we have them breathing into a closed system where we can measure, you know, oxygen exchange and carbon dioxide and get a sense of their metabolic responses to exercise and so on. So that's a very advanced tool that we can use to really start to disarticulate, is it the lungs, is it the heart, is it the muscles, is it something else? But that's not a tool we would employ in every single patient. That's one we might employ in somebody who are a little bit unsure of what is it exactly causing the problem.
Mm-hmm. Okay. So thank you for, that was a lot of questions, and you
Yeah.
did a great job of answering them. And I think at this point, I just want to let people that are on the call know a little bit about a study that Dr. Fenton and I are involved with. And we're looking at dyspnea in people that have had a COVID infection, and specifically in adults that have had shortness of breath in the last 30 days that isn't related to something that's pre-existing, like a pre-existing heart or lung issue. And what we're trying to do is actually look at how severe the shortness of breath is and some of the characteristics of that dyspnea. And so we're doing that in a few ways. One is by using standardized measurements. And these measurements also include measures of things like fatigue and anxiety and depression and quality of life. So that's part of it. And then people come to a testing center to complete spirometry, which Dr. Fenton talked about. And also one of our physiotherapists or their student leads people through different types of exercise testing, including a few more things than you mentioned, like quadriceps strength testing and grip strength and all kinds of other things. And so people do these tests at the beginning, and then they do it again at 6 months. And you know, one of the things that we're doing is giving people a copy of their results so that they can take those results back to their family doctors or their primary care providers, so that, you know, if there's follow-up that's needed, they can arrange that. And what we're hoping to do is really to we've done quite a few tests already, and we've gone to Saskatoon and Regina, and we have some people from out of town, and we have a team that actually can go out to different centers in rural Saskatchewan and Prince Albert, You know, if we have enough people in one area, we can actually send the team out to do some of this testing. So if you're somebody, or you know somebody that has had shortness of breath for, you know, sort of in the last 30 days, and you've had COVID, we're trying to learn more about what's happening. And so Jill is going to post a little some information about, if you're interested in finding out more about the study, you can contact Jocelyn, who's our research assistant, and you know, we'd be really happy to learn more, because the more people that can participate, you know, it's fine to have people in France and Spain and Italy, you know, involved in tests, but we also really want to know what's happening locally. And I think Mark and I and the rest of our long COVID team we're really committed to trying to make improvements in any way we can to the quality of life and the outcomes of people with long COVID. So that's just my little plug for our study. And if you're interested, you know, everything, you know, the questionnaires are done by Zoom, and we'll make every effort to get out to meet you in a space that's good for you. So please, you know, consider it. So I think with that, we're happy to answer any questions, or I guess Mark would be happy to answer any questions about about dyspnea, and I would be very happy to answer any questions people have about getting involved with the study. So thank you so much.
Thank you both so much. You covered so much in a short period of time. I certainly learned a lot. Thank you. As Dr. Goodridge already mentioned, I did put some information in the chat, but we will make sure to send out a follow-up email to everyone that has registered tonight. It'll come in the coming days with the recording of tonight, as well as information about the study that they're talking about, a link as to how you can get involved. And if not you personally, it's even a great way for you to share with friends and family, colleagues, you know, even being research allies, if you will. So we will make sure we get that out to you. We have so many great questions. Oh my goodness, our chat has been busy this entire hour. I'm not sure if we'll get to all of them, but we'll certainly do our best. And I've tried to lump some of the questions together, okay? So if you guys are ready, this question is to either of you, but are you seeing people who experience shortness of breath after a COVID-19 diagnosis, and is that primarily their symptom, or do you tend to see people with other symptoms as well, like fatigue, or is it primarily just shortness of breath?
So I guess that one's probably best answered by me, as the physician that would be seeing these people. To be honest, dyspnea in isolation, or shortness of breath in isolation, is not as common because most patients have more than one symptom, honestly. And
Okay.
like that's a well-documented thing throughout pretty much any study that's been done on this area, is that people present with multiple symptoms. And so fatigue is very common, shortness of breath is common, cough can persist for a while. Probably a third of people will have a cough that kind of prolongs for a while. And then, you know, there are often neurological things. So-called brain fog is one that people complain about a lot. So it's not generally in isolation, to answer that question. Yeah.
Okay. Thank you, Dr. Fenton. This question is for Dr. Goodridge. Is this study only for adults? What some people are saying that they have children that have experienced shortness of breath after a COVID-19 diagnosis. Can they get involved as well?
Right now, this study is only for adults, but we're increasingly hearing from people that from parents, and also from even youth that are experiencing long COVID symptoms. And my hope is that we can start to look at something for youth and children very soon. But this study right now is only for adults. So hopefully in the future we can do something with youth, because there's, you know, and there's not a lot of resources for children and youth. Like when I looked at what was available, because I've had parents contact me, there's a long COVID kids Facebook page, and there's one in Canada, and that's about the only actual resource that I could find. Like it's international, so I think the resources for children are actually quite limited, and we don't know as much about long COVID in kids. What I've read is that it's similar picture in terms of the proportion of children that experience symptoms, but the symptoms are different. Like there's a much higher prevalence of things like encephalitis and other things that we don't see in adults. So there's even more questions I think about children than there are about adults, but that's a great question. Thank you.
Okay, well, we'll see what the future brings there. Thank you. Okay, this question is for Dr. Fenton. Dr. Fenton, there's some people that have been experiencing ongoing chest pain after having a COVID-19 infection. Would you recommend a potential referral for this? And if so, would it be more so to respirology or cardiology or both?
Right. So chest pain actually is a pretty common complaint afterwards, and it tends to also go down in prevalence as time goes on, just like shortness of breath does as well. But if it's continuing, it really depends on the character of the chest pain as to sort of what direction one might go. In men, in some ways, it's a little bit easier because women present with cardiac chest pain differently than men. We know that. And so I always have sort of a lower threshold for asking a cardiologist for some thoughts on a woman than say a man, because it's just a little bit easier to tease out clinically. So, I would rely on your doctor's judgment where they start with that.
Okay.
And whether, and in some cases, they may not need a specialist to see them regarding it, because it may be a musculoskeletal issue, something that is not, something that doesn't need a specialist's attention necessarily too.
Okay. Okay. And that's positive that you're seeing that chest pain decrease often in time. That's a good thing to take from that too. So thank you for answering that. Dr. Goodridge, we have primarily people joining us tonight from Saskatchewan, but we do have people from all over Canada that have also taken interest to this. People are asking if they're not a Saskatchewan resident, can they take part in the study?
Unfortunately not, because it requires actually, well, I mean, we'd love to see more people in Saskatoon, and you're welcome to come and visit, but the testing actually has to be done in person. So the spirometry testing is done in person, and the exercise capacity is done in person.
We have people asking if they can travel to see you for that.
Well, if people are interested, I mean, those are tests that I'm sure are available in different provinces. The spirometry is something that's pretty commonly available, and the exercise capacity testing is something that many physiotherapists do. We're also really interested in the whole experience of dyspnea, and because it's multidimensional, because there's so many facets we have to understand, because it's not just your lungs and it's not just your heart, it's you as a person, right? It's multidimensional. And so I think one of the things our study is really going to add is a better understanding of what are the sensations, like what is it like, and how is it different from other kinds of dyspnea, like if you run a race, right? Or if you have COPD, or if you have asthma, like how is that different? So I think that's what it's going to add. But I think if anybody wants to talk to me, I'm happy to to talk to them about what we're doing, and if they want to come to visit, then I'm always open to out of province visitors.
Wonderful.
Yeah, you don't have to have an address in Saskatchewan to participate in the study. Like, that's not a rule of the study, but pragmatically speaking, the answer is you probably do, because like it's expensive to travel, right? That's where that answer is coming from, really. But if somebody was really bound and determined to participate in this study from wherever, they wouldn't be turned away.
Right. Okay. Perfect. Thank you. Are you seeing less long COVID after people have been vaccinated or boosted, or with after they've been infected by different variants such as Omicron versus Delta?
Yeah, good question. So the data to date would tell you that being vaccinated reduces the probability of, number one, getting infected with COVID. But if you are, much less likely to be dealing with something like long persistent symptoms. So long COVID is less in the vaccinated population. There's emerging evidence that different variants will behave differently on this. And so, you know, the Omicron, there's a bit of a signal that maybe there's less long COVID, but I don't know that we've been able to pin that down like definitively. And then of course, Omicron's in the rearview mirror already, and we're into another one now that also spreads very easily, but doesn't seem to be any more problematic than Omicron. So again, it remains to be seen with each variant how that plays out. And similarly, we're boosting, and what does that happen? You know, or what does that? How does that impact that? I don't think anybody knows. So
Okay.
Yeah, and I think I was just going to say some of the research really suggests that people that had an infection with the Delta variant might be more at risk for long COVID. So, you know, we're still looking at, you know, I mean, the evidence is changing all the time, and so that's possible. And I've certainly read that in the scientific literature, but you know, there's nothing's been proven.
Yeah, I mean, and the literature evolves, and like the measurements get better as time goes on because people are not scrambling to put stuff together. They're thinking through with proper, more sort of robust methodologies too. So, you know, like the overall prevalence of long COVID was thought to be actually potentially very high initially. And now it's estimated at around 6 to 10% of patients that have had COVID will end up with long-term symptoms. And, you know, we may discover that that goes up a little bit or down a little bit depending on how things evolve. And I agree with what Donna said, that there seems to be a bit of a signal surrounding the the Delta variant, and even the original, the wild type as well.
Okay. Thank you. Yeah, it's always evolving, isn't it? And time will often tell. So thank you. All right, so we have questions about we talked a little bit about exercising and physiotherapy. There's this kind of a two-part question. The first one is, would you ever recommend for patients that maybe are struggling to get moving again to try and enroll in a pulmonary rehab program? And the other part is, would you ever recommend, excuse me, using something like a respiratory training device? There's many out there. Something like there's the breather that has some you blow into and has some resistance, or incentive spirometry devices, anything like that. If you're experiencing shortness of breath after a COVID-19 diagnosis.
Okay, so part one, pulmonary rehab. I think my my patients would tell you that I'm probably the world's biggest fan of pulmonary rehab because I am forever telling patients to go to it because it's really valuable. You know, in the context of COVID-19 and dyspnea related to that, you know, I don't have science behind me to say, oh, well, if you enroll patients in pulmonary rehabilitation, this is what happens compared to patients that don't, right? I don't have that particular perspective on it, but I do know that it's a valuable thing for the following reasons. People build community there. And that actually is a really important thing, to be around people that understand you and where you're coming from. Number two, if you're exercising with a friend, you actually do more, perform better. Like that's just the science tells us that. So, and then in other diseases, I can talk to you about, well, it keeps them out of hospital, all that, but I won't today. In terms of those other devices, you could go simple and just do deep breathing exercises on your own without buying a device that creates resistance and so on. Because if you're feeling short of breath and then you start breathing through a straw, that's not going to feel very comfortable. So, I think you could just do simply big, deep breathing exercises to start with.
Okay. Okay, wonderful. Some great advice, and yeah, certainly another thing with pulmonary rehab is, you're supported by experts. So you're
Mhm.
not guessing what to do first with your exercise, right? They'll tell
Yeah.
you.
Well, that's actually an excellent point. I mean, there is an element of supervision there, which for the person that's nervous about this, actually there's a layer of psychological safety that comes with that too, but also really good advice, as you
Yes,
said. Yeah.
absolutely. Thank you. Okay, so there's questions about, there's several patients that have said since they've had COVID-19, they've lost their voice.
Mhm.
And whispering is really challenging for them, and it's making them feel short of breath. Do you see that? And do you recommend anything? There's actually one individual in here that said they're a singer and they have been unable to sing. So do you have any recommendations with that?
Right. So if somebody with any viral infection, if someone loses their voice afterwards, there's a sort of mental checklist. Is it that they've got postnasal drip and some laryngitis from that and so on? If it's a really persisting thing, maybe there's an issue with the vocal cord, one or both of the vocal cords themselves, and that to me would be best evaluated by an ear, nose, and throat specialist, because they can actually go in and just have a look and see, does these vocal cords move properly and so on. That's, I think, a really important thing. I personally haven't seen that as a common presentation at all, to be honest. So I don't have a lot of experience with that particular complaint. But that would be my thinking around it, that, see your family physician, of course, and I'm almost certain that this person would have, because I'm sure it's distressing them. But having someone that can look at the vocal cords, I think, is really important.
Okay,
I think,
great advice.
Jill, I wanted to say too that I've talked to actually a number of patients that have that problem, and some of them have found speech language pathology has been very helpful for them. And
Okay.
so that could be something that that they might want to check out, because speech language pathologists can, they're expert at assessments. They can, they're used to working with people over time to enhance their own capacity. If it's not something that is medically remediable, there are rehabilitation kinds of things that a speech language pathologist could do. And I think that's really, really a valuable thing to consider if there's not a medical issue that's the cause.
Yeah, for
Okay.
sure. From a therapeutic perspective and the retraining that comes with, where that's a persistent issue, I totally agree with you, Donna, and that's really good advice. I stand by, let's see what it looks like first, but yeah, I think that that's really, really wise.
Okay, great. There's questions about, so a lot of people thanking you, Dr. Fenton, for explaining the difference between spirometry and what it can measure and when you would move to something like a full pulmonary function test. There's
Mhm.
questions about there's two parts here. If spirometry is abnormal, would
Mhm.
you automatically order a full pulmonary function test as well? And then the second part of the question is, if the spirometry is abnormal or normal, but symptoms persist, would you repeat that test after a certain period of time?
So the first question is that I don't reflexively order a full pulmonary function test just because there's an abnormality on spirometry. It depends on I always have to contextualize a test to a patient. And then, but there's some that I would be more inclined to jump on full pulmonary function tests. Like, for example, if I thought there was a pattern suggestive of what I called a restrictive disease before, then I need a full pulmonary function test to start to make sense of that pattern. and help me. It really does guide me in my thinking around, is this an in the lung problem, an outside the lung problem, and so on. So there are certain instances where that would be a sort of reflex for me, but many times I would have to think through, well, marry the patient to the test and think through it that way. And then the second question, can you repeat that?
Yeah, so the second question is about if someone has a spirometry test done,
Oh, yeah.
whether it be normal or abnormal, if symptoms persist, would you redo the test after a certain period of time? Can the test change over time, is what people are wondering.
Yeah, so if you're presenting, let's say I've got symptoms today and I can walk 2 blocks. That's all I can do. That's my capacity. And somebody tests spirometry in me and it's normal. And 3 months from now, I can walk 2 blocks. I can't, like, it's the same. I don't see a point in repeating the spirometry in that situation, right? Nothing really has changed. In 2 months, I can't get out of the house because I'm too short of breath. Pretty extreme difference, but just trying to illustrate the point. I would probably repeat the test because maybe something has changed, right? The patient is changing. Yeah. If it's abnormal, depends on what the abnormality is and what I'm doing about it as to when I might think about repeating that test. So again, contextualize to the care plan that's personalized to that patient, really. Yeah.
Perfect, thank you. Okay, I'm being mindful of our time,
Good.
but I do want to ask you each just one more question, and they're both similar. So, Dr. Goodridge, people have gotten to know you. They've seen you in in many different ways. They've seen you through different avenues of Lung Saskatchewan. They're seeing you on social media and in the media with all your research around COVID-19. And you're getting to be quite well known in Saskatchewan. People are wanting to know why this is so important to you. Why is helping understand long COVID and helping people with long COVID so important, and why are you so passionate about this?
Well, that's an interesting question. I think it's because I've had the chance to talk to so many people with so many stories that have touched me profoundly, because I think that maybe in some small way I can make a difference by my efforts. And I continue to try to do everything I can and hope that in the end we will sort of kind of move forward together. And I have to say that I have so much appreciated everyone who's given me the pleasure and the opportunity of getting to know them a bit better. So yeah, thanks.
Well, thank you for all you do, and thank you for being here tonight. And Dr. Fenton, a question, kind of similar questions for you. Um, we know that you help people on their lung transplant journey. So you help people who have been diagnosed with diseases that we have been treating for decades now. People are wanting to know, because it must be very challenging for you as a respirologist and expert that can usually point to evidence-based research on how to treat,
Mhm.
fix, help with these other known conditions. People are wanting to know why you are focusing your research on COVID-19, and if you feel like in the future you'll be able to treat it more easily like some of the other diseases like asthma or COPD.
Okay. So, yeah, I mean, I think the question actually answers itself in terms of why it's important to me, because this is an important thing in my life. I practice in respiratory medicine, and these are patients that become my patients. Backing up just a little bit, I also have personal investment in COVID-19 from the perspective of I was very involved in how we responded to COVID within the acute care and actually across the system in Saskatchewan. And I had a very direct view of the impacts of this virus and the disease, not only on the system, but on the people that are the users of the system. And so, So there's a lot of reasons why this is important to me. Do I envision a time where we might be better at dealing with this? I do. I mean, the first step in sorting out any disease is characterizing it, and that's where we're at right now, right? We do have some treatments for acute COVID, right? We've had Paxlovid, and sotrovimab, and other things, but in terms of this sequelae of the infection that lasts in some people, we're in the discovery phase still. We're in the describing, digging in, and that's part of what we're trying to do here, is to dig in to try and characterize things a little bit better, to see if we can tease out some areas that we can focus on for therapeutic purposes. And so I do have some optimism there. I do. I can't tell you what those things are going to be yet, though.
You don't have that crystal ball yet, hey, Dr. Fenton?
No, my crystal ball is just a little bit busted. Yeah.
Well, thank you both so much for being here, and thank you to everyone that has joined. And we had such great conversation in our chats and so many great questions. I do apologize if we didn't get to all your questions. We tried to lump them all, and thank you for your comments. I will share them with our presenters. As mentioned, this has been recorded. We will send a follow-up email with this recording, as well as information about the study that Dr. Fenton and Dr. Goodridge are leading and part of, and invite you to be part of that study as well. And we really hope that you will take part or share with friends, family, colleagues that you think may benefit from the study, or maybe a great participant to the study. So on that note, everyone take care, stay well, and breathe. I hope everyone can breathe a little bit easier tonight.
Awesome. Thank you so much, Jill, and thank you to Lung Saskatchewan.
Yes, thank you.
Take care, everyone. Bye.